Hi, everyone, and welcome to this presentation on post-traumatic stress disorder using a cognitive behavioral therapy framework to approach treatment. My name is Annick Nestruck Beaupré, and I am an intern at the Emotional Health CBT Clinic, where I am completing my master's in counseling psychology. Today, we will be discussing what PTSD is and what its presentation can look like, as well as how CBT can be used to treat those impacted by it. Thank you all for taking the time to watch this presentation, and let's dive right in. So when considering an overview of PTSD, it is important to understand what PTSD is, its diagnostic criteria, and what factors may lead to developing PTSD. It is also important to consider who is most at risk for developing PTSD and why seeking treatment is so important. Following this overview, we will jump into specific cognitive behavioral strategies that are used to treat post-traumatic stress disorder. So PTSD is recognized as a disorder that results from being exposed to one or more stressors or traumatic events. More specifically, and important to PTSD, is that the person has had exposure to actual or threatened death, serious injury, or sexual violence, either directly or as a witness. PTSD can also result from learning that a traumatic event, characterized by being violent or accidental, has happened to a close friend or close family member. Another possible way that an individual can develop PTSD is if they're exposed to really unpleasant details of a traumatic event. An example of this would be a first responder or a police officer that is often exposed to aversive situations, such as a crime scene. So PTSD can only be officially diagnosed 30 days following the traumatic incident, and following the 30 days, PTSD can present itself within months or even years following the event. So PTSD typically develops following either an acute or sudden trauma, or as the result of chronic stressors and traumas that occur over time. These traumas can result from interpersonal violence, such as childhood abuse or neglect, sexual assault, intimate partner violence, just to provide a few examples. Mass interpersonal violence typically involves a high number of injuries or casualties, but does not occur in the context of war. Natural disasters, war, motor vehicle accidents, fires and or burns, the witnessing of or being confronted by the homicide or suicide of another person, or facing life-threatening medical conditions are other possible sources of trauma that can lead to PTSD. So to be diagnosed with PTSD, an adult must have all of the following symptoms for at least 1 month. So at least one re-experiencing symptom, at least one avoidance symptom, at least 2 arousal and reactivity symptoms, and at least 2 cognition and mood symptoms. Additional diagnostic factors include that the disturbance causes clinically significant distress or impairment in functioning, and that the disturbance is not associated with the physiological effects of a substance. And although not explicitly mentioned in the diagnostic criteria, it can be important to consider other symptoms, such as somatic symptoms. So typically, re-experiencing presents itself as flashbacks and intrusive thoughts and or memories of the trauma, as well as in physiologic reactions when exposed to stimuli that is reminiscent of the event. So avoidance symptoms can be cognitive, for example, avoiding or suppressing upsetting thoughts, feelings, or memories, or they can be behavioral in the form of, for example, avoiding activities, people, places, or conversations that could trigger memories of the stressor. The re-experiencing symptoms of PTSD are often the first to fade over time, whereas the avoidant and hyperarousal symptoms can present themselves over longer periods of time. Arousal and reactivity symptoms, such as hyperarousal and hyperreactivity, can be experienced in the form of jumpiness or a lowered startle response threshold. Negative cognitions and mood include not only diminished interest, detachment, and amnesia, but also include persistent negative beliefs and emotional states. Somatic symptoms are also important to consider, although not explicitly detailed in the diagnostic criteria, as aforementioned. Those with PTSD have been shown to have increased rates of nervous system disease, circulatory problems, digestive disorders, and chronic pain, making it important to evaluate all symptoms. A PTSD diagnosis can come with certain specifiers. The dissociative qualifier reflects recent research documenting significant dissociative symptoms among those impacted by PTSD, especially those with early and repeated trauma and greater comorbidity, and are experienced in the form of depersonalization and derealization. Depersonalization is experienced as a persistent or recurrent experience of feeling detached from one's mental processes or body. So, for example, feeling like an external observer looking into your reality and seeing kind of yourself from an outside perspective. Derealization is experienced as a persistent and recurrent experience of unreality of surroundings. So, for example, the world is experienced as unreal, dreamlike, distant, or even distorted. An additional specifier is called delayed expression. And this is when the full diagnostic criteria of PTSD is only met 6 months or more following the traumatic event. So when considering who is at risk for PTSD, it's important to recognize that although undergoing one or multiple traumas may result in PTSD, not everyone will develop PTSD. Statistics show that up to 90% of people will experience an event characterized as traumatic, and out of those, 25 to 35% will develop PTSD. To help explain this, it's important to consider risk factors such as childhood trauma or previous trauma exposure, feeling horror, helplessness, or extreme fear during the trauma, having little or no social support after the event, dealing with extra stress after the trauma, such as loss of a loved one, pain and injury, or loss of a job or home. Additionally, having a personal history or family history of mental illness or substance abuse is also a risk factor. Factors that may bolster resilience to developing PTSD include seeking out support from friends and family or support groups, learning to feel okay with one's actions in response to a traumatic event, and having coping strategies set in place. So when looking at examples of victim-specific variables, these include gender, with women facing 2 to 3 times higher risk compared to men for developing PTSD. Age, with younger or older individuals being at greater risk than middle-aged people. Race, with Black individuals and Hispanics at higher risk compared to Caucasians, and having a lower socioeconomic status. Because PTSD is often associated with other comorbidities, such as major depression, substance abuse, and various anxiety disorders, treatment can help in the prevention or treatment of other mental health difficulties that can significantly impact well-being and quality of life. Up to 80% of individuals with a PTSD diagnosis have at least one other psychological disorder, such as depression, substance abuse, or anxiety-related disorders. Additionally, due to the association between a post-traumatic stress disorder diagnosis and suicidality, treatment can help mitigate these risks. Additional reasons to seek treatment include regaining control over one's life, learning the skills necessary to address the symptoms, and then as a result, having the tools to use when these symptoms arise again. Importantly, Treatment can help a person have a more realistic and positive perception of self, others, and the world, which is often negatively impacted following a trauma. So now I would like to shift to addressing the treatment of PTSD using cognitive behavioral approaches. So cognitive behavioral therapy aims to get a better understanding of how our thoughts, beliefs, and behaviors are connected to our moods, physical experiences, and events in our lives. So using CBT to treat PTSD involves several processes, such as the evaluation of the traumatic event, psychoeducation, the working on identifying emotions, and restructuring thoughts through the use of techniques such as cognitive restructuring. Relaxation techniques are also often implemented to help mitigate the effects of trauma. A CBT technique called exposure, which has two different types, in vivo exposure and imagined exposure, will also be explored. Another important element of CBT, and particularly in trauma work, is the establishment of a strong and trusting therapeutic alliance with mental health care workers, so that for those who have faced trauma, they can feel well-resourced and safe in their healing journey. So in the evaluation phase, the first thing we want to do is briefly review the traumatic event without too many details in an effort to prevent causing undue distress or the triggering of PTSD symptoms. So here we would want to get an overview of the traumatic experience without any traumatization or dissociation. Following this, we would like to discuss the event, the level of functioning of this individual by exploring areas such as relationships, their job, and home life. Pre-traumatic events are also important to consider, since, as we mentioned earlier, there are several predisposing factors that can impact the way someone integrates a traumatic event. We would also like to get an understanding of maintaining factors. So these are things that could be maintaining the symptoms, such as avoidance, safety behaviors, and biased memory or thinking patterns. Filling out questionnaires and standardized tests can help gain further clarity for the person experiencing symptoms, and this can be achieved through the use of scales, such as the PTSD symptom scale and the impact of event scale. It's also important that a person feels safe and is in a safe environment when processing their traumatic event. Here we are looking not only at readiness to address the trauma, but whether they are currently in a safe environment. Because if they're currently experiencing a trauma, for example, in situations of interpersonal violence, trauma work may not be ideal. It is also important to consider if there's a presence of suicidal thoughts or intentions. Important to the evaluation phase is also ensuring that one's symptoms meet the diagnostic criteria for PTSD and not another disorder such as adjustment disorder. Once the evaluation phase is complete, it's important to be well-resourced with information on PTSD and its treatment. Psychoeducation can also be employed in an effort to normalize and validate one's traumatic experience both during and following the traumatic event. One approach to this would be to explain symptoms as a normal reaction to an abnormal event. Feeling extreme levels of fear, often present in moments of trauma, is really powerful and can put us into a state of survival that we can have a hard time understanding. Psychoeducation can also help gain perspective on the array of emotions that often come along with PTSD, such as anger, shame, guilt, and powerlessness, that the person may have never experienced prior to their trauma, or conversely, that they may have been experiencing due to persistent interpersonal abuse. So psychoeducation can also help those with PTSD better understand their behavior during the traumatic event, which they may have trouble consolidating. An example of this could be a sexual assault victim who feels guilty because they think they did not do enough to get away after they went into a freeze mode during their assault. Here we can discuss with them how the fight, flight, and freeze responses work, and can help validate their experience by reminding them that the behaviors they engaged in during their traumatic experience led to their survival. Explaining their reaction to others can be useful as well. Following a traumatic event and dealing with PTSD can lead to negative responses from others, which can present themselves in the form of, for example, victim blaming, blaming the reaction of the victim for the trauma occurring, and blaming the victim for the timeline of their symptoms, which can look like saying, "It happened 6 months ago. Why aren't you over it yet?" So by explaining the reactions of others as reflecting a way for them to feel a sense of control and safety over their lives, or possibly as a way to avoid facing the reality of what happened to the victim, then this makes sense as these responses become more about the other person and not the victim themselves. So the upcoming slides will be discussing the different cognitive behavioral techniques that are used to help overcome PTSD and its symptoms, such as the importance of processing and identifying emotions and thoughts through cognitive restructuring, as well as through exposure therapy. So while doing the work of reprocessing a trauma, it can be very helpful to engage in relaxation and grounding techniques to really help the victim develop ways to actively reduce their stress responses through treatment. An example of this would be a technique called grounding, where the person is encouraged to elicit present moment awareness through touch and other senses. Deep breathing techniques can help shift one from fight or flight mode into a more rest state. Techniques such as diaphragmatic breathing can also be used to help bring a person into the present moment. Breathing techniques can be found in many different media types, such as books, YouTube videos, and apps, allowing them to be really catered to individual preferences. Progressive muscle relaxation, or the systemic and intentional tension and release of major muscle groups, can help with symptoms of anxiety and sleep disturbance. Other forms of relaxation include yoga, art, exercise, meditation, and so on and so forth. It is important to stress the benefits of self-care throughout the PTSD healing process. So one of the best ways to achieve a greater sense of emotional regulation is to develop the ability to correctly perceive and label emotions as they are being experienced in the body. So by encouraging some emotional detective work, it can become more clear how emotions are linked to behaviors and also thoughts. Our emotions are closely linked to our thoughts and behaviors, and as a result, impact not only the decisions we make, but the way we perceive our world. For example, people may feel guilty about their reaction to the trauma or shameful that they experienced the trauma altogether. However, avoidance of these emotions inhibits the ability to process the trauma, and as such, prevents the person from experiencing a reduction in intensity of these emotions. So in delving deeper into the importance of processing emotions, we can break down this process into 4 steps. The first entails noticing how emotions are experienced in the body. Some people with PTSD may have a difficult time labeling emotions, and so exploring the feelings in the body can help to more accurately identify the emotions being experienced. Once emotions can be identified, along with their relationship to somatic sensations, working on accepting the emotions as valid responses to what happened to them can help neutralize them. In the context of processing your emotions, accepting means ending the struggle against the emotion. Usually, this means letting it be felt in your body. What we often do instead of accepting is to abandon the experience altogether in favor of something distracting, such as avoidance. This is what fuels many of the enduring PTSD symptoms, such as avoidance and dissociation. Acceptance is assisted by being able to take refuge within ourselves. It is a choice we make moment to moment. We will meet this emotion and permit it to exist within us. It is about allowing ourselves to feel what is a natural consequence of our experience without letting it define us. A final element to processing our emotions might include taking some action to express these emotions. For example, allowing the big emotions to come through in the form of crying, having the capacity to discuss these emotions with others, or to process them through behaviors such as journaling or letter writing. These methods geared towards emotional expressiveness may mean adapting a practice or practices as a way to make sure that situations are more peaceful for yourself. Okay, so now let's shift to the thought element of the CBT process. Thoughts are another important element to address when attempting to reprocess and heal from post-traumatic stress disorder. Thoughts often go unnoticed, and so the influence they have can also remain unnoticed. Just like how emotions impact our behaviors and thoughts, our thoughts are also connected to our emotions and behaviors. For example, if a man is walking purposefully towards me on the street and I have the thought, this man is going to attack me, then that thought might be associated with different feelings such as fear and behaviors such as running away. Conversely, if I had the thought, this man must be in a rush, which could be more associated with feelings of indifference and could result in a lack of behavioral response altogether. So this is where it becomes important to identify automatic thoughts and identifying how these thoughts are contributing to the maintenance of PTSD symptoms. Examples of common themes where we can find maladaptive thought processes resulting from a trauma center on safety, security, power, sense of control, one's self-esteem, and beliefs about intimacy. Through identifying automatic thought patterns, triggers of symptoms can be more easily identified. Successful trigger identification can facilitate a greater sense of control and better interpersonal functioning by providing an opportunity to alter situations in which these triggers might occur and problem solve negative states as they emerge and before they influence a particular behavioral response. Cognitive restructuring is a CBT technique that helps with shifting thought patterns and can help when a person is feeling stuck in these negative thought patterns. Cognitive restructuring involves challenging identified thoughts and beliefs through strategies such as looking at the evidence that supports versus the evidence that does not support the identified thought. Through strategies such as calculating probability of a particular thought coming true and creating more realistic and balanced thoughts, then better neutrality can be achieved. Cognitive restructuring can also help mediate cognitive distortions that may result from experiencing a trauma, such as magnification, otherwise explained as an over-exaggeration of a thought. This type of thinking leads to worries escalating quickly and becoming the worst case scenario type thoughts. Another type of cognitive distortion that can be associated with PTSD is personalization, where one will self-blame for circumstances beyond theirs, as well as assume that they have been intentionally targeted. A basic example of cognitive restructuring can look like the following. A person has a thought, what happened was my fault, which is then associated with negative emotions and, for example, self-isolating behaviors. And through the use of Socratic type questioning or open-ended questions, a more balanced and realistic thought and evidence can be teased out. Questions such as, how can we reassess responsibility? Is there any information that suggests that this thought is not completely true? If my best friend or loved one had this thought, what would I tell them? All of these questions can be useful. Following this exploration, The construction of a more balanced thought can occur, such as many factors of this situation were out of my control, and I did what I had to do to survive. Important to an alternative thought is that it is more balanced, and that does not necessarily mean going to the other extreme, such as what happened was not my fault at all. There may realistically be some responsibility. However, a more balanced thought can help with feeling stuck and can attribute a different meaning to the situation. So in shifting to exposure therapy is a technique used in CBT to help people overcome fears and anxieties by breaking the pattern of fear and avoidance and reprocessing the traumatic memories. Important to exposure therapy is that memories about the trauma are not the same as the trauma itself. So because memories about the trauma are not the same as the trauma, through exposure, we can learn that these memories and associated cues are not the actual trauma happening in the moment, and that although distress is not pleasant, it can be tolerated and reduced over time. So by conducting exposure in a safe space and with the guidance of a therapist, an individual can begin learning that they can safely experience these reminders. These memories, however, can lead to avoidance behaviors such as avoiding a particular place or people or avoiding certain emotions and thoughts. As we previously discussed, avoidance is a central component of PTSD, and it can increase levels of fear over time. What exposure does is that it helps to reprocess these memories, thoughts, and other variables that have now been linked to the traumatic event over with the purpose of over time creating a desensitization process that results in a more balanced experience of the memories and events. The outcome goals for exposure therapy include developing a sense of mastery over one's emotions and bolstering self-confidence by, for example, realizing you can cope with more than you had thought, and also gaining a sense of emotional closure around the traumatic event or events can be a very powerful experience as well for trauma survivors. We know that PTSD often involves a level of avoidance, either of internal thought processes or external variables, and avoidance has a tendency to increase fear over time. And so through exposure, we can reestablish a fear structure so that these emotions, thoughts, and situations can eventually be perceived as safe, even though right now they are being perceived as unsafe. The goal is to slowly habituate to the strong emotions or thoughts we identified, and over time and over a number of exposure sessions, with hopes of seeing a reduction of these emotional responses. Earlier, I mentioned that there are two types of exposure techniques. The first I will be discussing is in vivo exposure, where the person is exposed in real life to safe situations or people, and this can be done alone or with a therapist. This is done very slowly and in small steps to avoid overwhelming the person so that they can stay present in the moment, in their body, and can cultivate a level of anxiety that is tolerable and that they can sit with and eventually become desensitized to. So building a hierarchy of fears can help ensure that the process is going at the appropriate rate for the individual. It is important to start small and then build from there. So a way to begin this process can be to first test out a hypothesis with the person about what some consequences might be following exposure to a certain stressor, and then selecting an exposure opportunity that has been rationalized and is perceived as tolerable. For example, if someone was involved in a robbery at a grocery store and as a result avoids grocery stores, they may start by working on being able to sit in the car with the intention of going to a grocery store, followed by driving to a grocery store, followed by sitting in the parking lot of a grocery store, so on and so forth, until they can bring themselves to actually enter a grocery store again. So the second type of exposure is imagined exposure. Sometimes in vivo exposure in the context of a person's particular trauma may not be safe, and so imagined exposure can be used to reprocess those memories and events. This strategy uses the same idea as in vivo exposure in that it uses a hierarchical approach by first telling the story in a basic manner and over time gradually increasing the level of detail and emotional connection to the memory by, for example, encouraging the person to explore all of their senses in the retelling of the event or retelling the event in the present tense. Imagined exposure should feel less distressing as the person is typically being supported by a therapist and is in a safe or neutral environment. A strategy that can help consolidate this imagined exposure strategy could be to record the narration of the traumatic event or memory and then listen to it repeatedly to try and reduce the strong negative reactions to the event. After the exposure process is done repeatedly, it could be useful to discuss how this person felt while revisiting the trauma context and if they've cognitively restructured it in any way on their own. This can also help the individual gain a new perspective on what happened during and after the trauma. In conclusion, the overarching goals are to decrease post-traumatic stress disorder symptoms, bolster coping mechanisms, and to create a plan for relapse prevention. So I want to thank all of you for taking the time to listen to this presentation, and I'm so looking forward to answering any questions in the Q&A forum that will follow.